everyone, hope you're all doing good. In this video, we are going to discuss about pelvic inflammatory disease. Now, let us see what is the definition of pelvic inflammatory disease first. So, definition, you have to know that pelvic inflammatory disease is a disease of the upper genital tract. Okay, remember it is a disease of upper genital tract. So, this is a spectrum of infection. Okay, it is a spectrum of infection and inflammation of the upper genital tract, typically involving the uterus, fallopian tubes, ovaries, pelvic peritoneum and the other surrounding structures. Okay, so these are the 2 points you have to know. Okay, so first one you have to know it is the disease of upper genital tract. There is infection as well as inflammation that is seen mainly in the uterus, tubes, ovaries, peritoneum and adjacent structures. Remember, I am not mentioning cervix and vagina. So, cervicitis or vaginitis is not included in the terminology of pelvic inflammatory disease. Clear? So, another important point what you have to know is pelvic inflammatory disease is also not related to surgery or pregnancy. Clear? Right. If you ask me about the incidence of pelvic inflammatory disease, this most commonly varies between 1 to 2% every year and mostly seen in the women who are sexually active. Okay, and in that 85% are seen as a spontaneous infection in sexually active females of reproductive age and 15% will be seen following the procedures they undergo. Clear? And pelvic inflammatory disease is a major problem to the women of young age. Okay, because it can result in infertility. Clear? Now, let us see the epidemiology. There is a shift from inpatient to outpatient management nowadays. That is the important point. And then there is a change in clinical presentation as well. Okay, nowadays less severe disease only is commonly seen. Also, microbiology, that is being the etiology of pelvic inflammatory disease, there is a change. Okay, so like we are seeing more Chlamydia, trachomatis cases nowadays than other organisms, especially than gonorrhea itself. Okay, right. So, what are the risk factors of pelvic inflammatory disease? This is seen in menstruating teenagers who are having multiple sexual partners. There is absence of contraceptive pill use, who has a previous history of pelvic inflammatory disease, who is an IUCD user, intrauterine contraceptive device user, and finally, in area with high prevalence of sexually transmitted disease. Okay, so these are the risk factors. What are the risk factors? When they are menstruating teenagers, when they have multiple sexual partners, absence of contraceptive pill use, there is a previous history of pelvic inflammatory disease, history of IUCD usage, and areas with higher incidence of STD. Okay, now let us see what are the protective factors as well. Okay, so protective factors include contraceptive practice first, that is very important. In contraceptive practice, barrier methods are advisable, especially the condoms or diaphragms that are with spermicides. Okay, and you can even advise oral steroidal contraceptives, and a woman whose partner had a vasectomy is also protective. Okay, so these are the contraceptive practices. So what are the other protective factors we can have? Means it is pregnancy, menopause, and some of the vaccines including hepatitis vaccine as well as HPV vaccine. These are some of the protective factors. Clear? Right. Now, we have to discuss about microbiology in pelvic inflammatory disease. As I already told you, it is going to be due to infection. Okay. So, acute pelvic inflammatory disease is usually a polymicrobial infection. Okay, and there is ascending up of organisms. Okay, so primary organisms are sexually transmitted usually, and they are mostly related to Chlamydia, gonorrhoeae, that is Chlamydia trachomatis, Neisseria gonorrhoeae, or Mycoplasma hominis. Okay, so in books it is mentioned like there is equal chance of Chlamydia, gonorrhoeae, and Mycoplasma has a 10% chance. However, clinically we see Chlamydia cases more than gonorrhoeae, as I have mentioned in the epidemiology. Clear? And apart from this, secondary organisms that are normally found in the vagina can also be responsible, and in that aerobic organisms will include non-hemolytic Streptococcus, E. coli, Group B Streptococcus, and finally it can also be Staphylococcus. Clear? And then anaerobic group of organisms that is causing pelvic inflammatory disease include bacteroids, fragilis, streptococcus and peptococcus. Okay. So, what are the criteria? Okay. So, define pelvic inflammatory disease. There is a criteria given by CDC, that is Clinical Diagnostic Criteria. Clear? So, in that we have minimum criteria and maximum criteria. Minimum criteria include lower abdominal tenderness, adnexal tenderness, as well as cervical motion tenderness, right? And then you can also have some additional criteria where the oral temperature can be more than 38.3 degrees Celsius. You can have a mucopurulent cervical or vaginal discharge. And here I will mention one thing. Most of the times purulent discharge means you have to think about gonorrhoeae, whereas watery mucus discharge means you have to think about chlamydial infection. Clear? Right. And then there can be raised C-reactive protein or ESR also. Okay. Right. So, apart from this, we also have a definitive criteria which will show histopathologic evidence of endometritis on biopsy, and there can be evidence of thickened fluid filled tubes that can be seen by MRI or transvaginal ultrasonogram. Clear? Right. So, these are the criteria that will be defining pelvic inflammatory disease. Now, let us see the pathway of infection. So, how the infection is entering? Pathway of infection starts with cervicitis, which will be leading to endometritis, and that will be spreading to the tubes causing salpingitis, ovaries causing uvaritis, and finally it can even form a tubo-ovarian mass, and finally that can even result in peritonitis as well. Okay. But as I told you, cervicitis is not going to be included in pelvic inflammatory disease, but as such it can be a cause of pelvic, it can be a root of pelvic inflammatory disease, right? Okay. Now, let me talk about the clinical features, symptoms and signs. Okay. So, the symptoms in pelvic inflammatory disease include bilateral lower abdominal and pelvic pain. So, this is the most common symptom you will have. Okay. Then there can be fever, lassitude or headache, irregular and excessive vaginal discharge, as I have discussed in the criteria. Okay, so that can be purulent or watery. Purulent means it is gonorrhea and watery means you have to suspect chlamydia. Even sometimes the women may present with nausea, vomiting, dyspareunia, pain and discomfort in the right hypochondrium. Okay, now this is seen in 10% of the women. Okay, so if you ask me why this is seen, means it is seen due to the adhesions, okay, adhesions that are formed between the anterior abdominal wall and the liver. Okay, so that will be leading to a perihepatitis, and if you see a gross picture of that, it will be like, so this is a picture of Fitzhugh-Curtis syndrome. Okay, so there are adhesions. This is the liver and this is the abdominal wall. Okay, I hope you are able to see numerous adhesions here, and this will be giving a violin string appearance of adhesions. Okay, so this is important, right? Now, after this, you will be taking the patient for examination. So, what are the signs that you will be seeing in a patient with pelvic inflammatory disease? Signs will include temperature that is elevated more than 38.3 degrees Celsius. You will be able to see during abdominal palpation, it will be revealing tenderness on both the quadrants of lower abdomen. That is lower abdominal pain will be there. Abdomen. Then there is vaginal discharge also while you do a local examination, and while doing a per speculum examination, you will be able to see congested cervix that is having purulent material from its canal. So, the discharge can be seen. And finally, when you do a bimanual examination, it will reveal bilateral tenderness. Okay, that is uterine or adnexal tenderness and cervical motion tenderness especially. Okay, so this is one specific symptom of pelvic inflammatory disease. Clear? So let's see what are the investigations to be done in a case of pelvic inflammatory disease. The first point is you have to identify the organism. For that, you have to send the discharge from urethra or Bartholin's gland, cervical canal, or the collected pus from fallopian tubes. Okay. When you do a blood test, the leukocyte count shows leukocytosis that is more than 10,000 per cubic millimeter, and there is also an elevated ESR that is more than 15 millimeter per hour. Okay. Then we can offer them a ultrasonogram where you will be able to see adhesions in the tube. You can also see hydrosalpinx, and perihepatitis feature that I have described under Fitzhugh-Curtis syndrome can also be seen. But the gold standard investigation for pelvic inflammatory disease is laparoscopy. Okay, remember this is the gold standard investigation. Okay, because apart from visualizing what has happened directly to the uterus, ovaries and the structures, adnexal structures, you can also be able to obtain a peritoneal fluid directly, or even this can be taken as a peritoneal wash, and it can be sent for culture and PCR in case of tuberculosis, and PCR or nucleic acid amplification test to detect chlamydia or gonorrhoeae. Okay, and sometimes cultosynthesis can also be offered. Clear? Now let's see what are the complications of pelvic inflammatory disease. Complications of pelvic inflammatory disease can be divided into immediate complications and late complications. Okay. Immediate complications include pelvic peritonitis and septicemia, whereas late complications include dyspareunia, chronic pelvic inflammation, formation of adhesions, that is, as I told, it can lead to Fitzhugh-Curtis syndrome. Then there can be chronic pelvic pain. There is an increased chance of ectopic pregnancy. There can be chance of infertility also. Okay. So one more point I have to add here is to know the probability scoring for conception. In pelvic inflammatory disease, we use a score called Boyer-Meisel score. Okay. Let's see the staging of pelvic inflammatory disease, how this will progress. Stage 1 is where there is no peritonitis. Stage 2 will have peritonitis. Stage 3 will be having a tubo-ovarian mass And in stage 4, there will be ruptured tubo-ovarian mass. Okay, this can be sometimes abscess also. Okay, so this is the staging of pelvic inflammatory disease. Clear? Right. Now, let us see the treatment or management of pelvic inflammatory disease. Okay, first step is we have to prevent pelvic inflammatory disease from happening. Okay, so that must be our primary goal. So, prevention can be done by community based approach to increase public health awareness. Second one, there should be prevention of sexually transmitted diseases, liberal use of contraceptives should be there, and finally routine screening of high risk population should be offered. Okay, so these are the ways of prevention: community based approach to increase public health awareness, prevention of sexually transmitted diseases, then liberal use of contraceptives and routine screening of high risk population. Okay, and when we go for management, the principles of therapy or to control infection, second one to prevent infertility, number 3 you have to prevent reinfection also. Clear? Right. So, when you are doing outpatient treatment, nowadays we are doing one-way outpatient treatment, okay, mostly. So, while doing outpatient management, we can give them yellow kit, which is the kit given for lower abdominal pain, that contains doxycycline at a dose of 100 mg BD for 14 days. Then it also contains metronidazole 400 mg BD, that will be given for 14 days, and it contains cefixime at a dose of 400 mg once daily, that is given for 1 day alone. Clear? Right. Next one is you have to treat the partner also with the grey kit. It contains tablet azithromycin 1 gram stat and tablet cefixime 400 mg stat. Clear? So, this is how the outpatient management is done. If you go for inpatient antibiotic therapy, there are 2 regimens. First one is regimen A, where you can give cefoxitin 2 mg IV bolus every 6th hourly. Okay. Then gentamicin 2 milligram per kilogram IV given as a loading dose. This will be followed by 1.5 milligram per kilogram as a maintenance dose, that is given every 8th hourly. Clear? Right. Then we also have an alternative regimen, that is containing levofloxacin 500 milligram IV once daily with or without metronidazole 500 milligram IV every 8th hourly. Clear? Right. So, what are the indications of surgery now? Surgery is indicated when there is generalized peritonitis or pelvic abscess or tubo-ovarian abscess. Okay. And what you should do to prevent reinfection? To prevent reinfection, you have to educate the patient. Okay, you have to educate the patient first, then they should be aware of the consequences of having multiple sexual partners and the use of barrier method of contraceptives should be encouraged. Clear? So, this is all about pelvic inflammatory disease. I think we have discussed in detail about it. So, let's all meet in the next video. Until then, keep going, happy learning and take care. Bye.